Welcome, everyone, to Unlocking the Power of SDOH ICD-10 Codes, a comprehensive guide for healthcare professionals. This webinar is presented by Karen Youmans, President and CEO of SDOH Consulting. This webinar will focus on the crucial role of Social Determinants of Health ICD-10 codes in enhancing patient care and health outcomes. For today's webinar, you are in mute mode. If you have any questions or concerns, please post them in the Q&A section. We will be monitoring this Q&A section throughout the webinar. The chat feature is disabled. Earlier today, we sent an email with a link to download the webinar slides. If you do not have access to that email right now, there is a link to the slides posted in the Q&A section. After this webinar, we will talk about how you can access your CEU Certificate of Completion. A little more about our presenter. Karen Youmans is the founder, president, and CEO of SDOH Consulting. Karen has over 30 years of experience in the healthcare industry and in the HIM coding profession. She is a subject matter expert on coding consulting, coding compliance, and corporate training. Karen has been president of Gulf Coast FAHIMA, state advisor at SAHIMA, president of FAHIMA, and member of the board of directors, chair, and director at AHIMA. If you or your team is attending AHIMA this month, send us an email to connect. Karen, take it away.
Thank you so much, Mari, and good afternoon, and thank you all for joining us. Today, we're going to be discussing social determinants of health and how it is so broad and affects so much data that is out there. It is truly one of the things that is happening in healthcare all over the world. So I'm excited to be sharing that information with you today. Let's just get a couple housekeeping things first. If you would take a moment to read or review the disclaimer here. I do want to point out that any references to AHA Coding Clinic or CPT or HCPCS codes are going to be brief because those are certainly copyrighted by the AHA and AMA. And we encourage everyone who is participating that they would have a full version of both of those publications, AHA Coding Clinic or AMA CPT HCPCS codes. It could be in electronic version, it could be through your encoder or CAC vendor, et cetera, but just wanted to point that out. So let's get started with our objectives. So learning objectives for today is really to discuss the World Health Organization and Centers for Disease Control definition of social determinants of health with influence on health equity, to highlight the impact on quality measures, MSDRGs, and work RVUs, and to review the ICD-10 codes along with tools and resources for appropriate documentation. Some of the slides I will be detailing, others I will go over briefly because we've provided you with lots of great references for you in the last few slides. So I'll highlight those as we go through them. So social determinants of health, or SDOH, has been increasingly recognized as a crucial factor in influencing health outcomes. As healthcare initiatives and coding practices continue to evolve, the implementation of SDOH ICD-10 diagnosis codes has gained prominence, reflecting the growth emphasis on addressing social factors to improve overall health and well-being. In this context, healthcare clinicians as well as coders need to understand the significance of these codes, their impact on quality measures, the evolving requirements for documentation reporting, and the data collected that impacts many national and international committees, policies, and therefore actually outcomes. So let's start with the big picture. The big picture is the World Health Organization. So the World Health Organization, or WHO, defines social determinants of health as non-medical factors that influence health outcomes. They are conditions in which people are born, grow, work, live, and age. These forces and systems include a wide set of forces and systems that shape daily life, such as economic policies and systems, development agendas, social norms, social policies, and political systems. As I reviewed the World Health Organization website, really got a bigger picture of what's happening worldwide. The WHO continues to discuss and have discussions on various levels regarding SDOH and the important influence on health inequities. They define the health inequities as the unfair but avoidable differences in health status seen within and between countries. In countries at all levels of income, health and illness follow a social gradient. The lower the social economic condition or position the person has, the worse their health is. The following list provides examples of the social determinants of health, which are focused of the World Health Organization that can influence health equity in positive and negative ways, such as income and social protection, education, unemployment, job insecurity, working life conditions, and things like social insecurity, housing, basic amenities, the environment, and access to affordable health services of decent quality. Research shows that social determinants can be more important than healthcare or lifestyle choices in influencing someone's health. For example, numerous studies suggest that SDOH account for between 30 to 55% of health outcomes. In addition, estimates show that the contribution of sectors outside of health to population health outcomes exceeds the contribution from the healthcare sector. Addressing SDOH appropriately is fundamental for improving health, reducing long-standing inequities in health, which requires action by all sectors and all parts of society. There is a phenomenal slide from the Global Commission on Social Determinants. This is from the WHO organization. We've given you references to that as well. There are challenges to overcome in implementing action to address health inequity through social determinants of health. It's a complex and multifaceted field. It involves a wide range of stakeholders within and beyond the healthcare sector and all levels of government throughout all the countries of the world. In addition, social determinants of health data can be difficult to collect and share. While the evidence based on social determinants of health have strengthened during the past decade, the evidence based on what works or needs to be strengthened and good practice disseminated effectively. There are three areas for critical action identified by the World Health Organization Global Commission on Social Determinants of Health, and they reflect their importance in tackling inequities in health. These include improved daily living conditions, which is the circumstances in which the individual does acquire health, tackling the inequity of distribution of power, money, and resources, as well as the measure and understand the problem and assess the impact of the actions. According to the World Health Organization, life expectancy and healthy life expectancy have increased, but unequally. There remain persistent and widening gaps between those with the best and the worst health and well-being. Poor populations throughout the world systemically experience worse health than richer populations. For example, there's a difference of 18 years of life expectancy between high and low income countries. In 2016, the majority of 15 million premature deaths due to non-communicable diseases occurred in low and middle income countries. Relative gaps within countries between poor and richer subgroups for diseases like cancer have increased in all regions across the world. The under 5 mortality rate is more than 8 times higher in people who are born, grow, work, and live in certain areas. For instance, Africa rather than the rest of the European region. Pursuing health equity means striving for the highest possible standard of health for all people and giving special attention to those at greater risk of poor health based on social conditions. Action requires not only equitable access to healthcare, but also means working outside of healthcare to address broader situations. The World Health Organization defines health equity as the absence of unfair, avoidable differences in health among population groups, defined by social, economic, demographic, or geographic characteristics. Health equalities are measured differences in health across population subgroups. Monitoring of those health inequities provides evidence of who is being left behind and informs health policies, programs, and practices that aim to close existing gaps and achieve health equity. There is a health inequity monitor, which is a daily repository of data. It's the largest global collection of disaggregated data about health and determinants of health, with nearly 11 million data points across more than 2,000. The World Health Organization website has amazing information about all of this, so I would encourage you, if you're interested, to look there. Then we'll go down what I call one level. Let's go to the United States here and go to the CDC. The CDC is an abbreviation, as we all know, for Centers for Disease Control, but it's actually Centers for Disease Control and Prevention. A lot of people forget that and prevention because it's not in the actual descriptor there. But they have taken on the same definition as the World Health Organization. They are non-medical factors that influence health outcomes. They are conditions in which people are born, grow, work, live, and age. And they continue on down the pathway for the United States. So according to the CDC, why is it so important? Well, they are saying that addressing differences in SDOH accelerates progress towards health equity, a state in which every person has the opportunity to attain the highest level of health. SDOH have been shown to have a greater influence on health than genetics or access to health care. I'm going to repeat that. SDOH have been shown to have a greater influence on someone's health than either genetic factors or access to health care. For example, poverty is highly correlated with poor health outcomes and a higher risk of premature death. Inequities in access to a range of social and economic benefits, such as housing, education, wealth, and employment. That puts, according to the CDC, puts people at higher risk of poor health. And the CDC is coordinating their efforts to focus its resources on the area where federal public health investments can make the most difference. We have another organization, of course, the United States HHS, which is the abbreviation for the Department of Health and Human Services. The Department of Health and Human Services actually started a program called Healthy People 2030. They have a mission of HHS actually is to enhance the health and well-being of all Americans by providing for effective health and human services and by fostering sound, sustained advances in the sciences underlying medicine, public health, and social services. Here's a diagram from Healthy People 2030. They have a lot of great objectives and visions and missions that between now and 2030, that a lot of these hopefully will be accomplished. HHS does have some top priorities here that they are working over they started in 2023 to 2030, of course. They're Healthy People, social determinants. They want to focus on these areas: education and access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. These are 5 key areas that HHS wants to focus on through this Healthy People. Some examples include safe housing, transportation, neighborhoods, polluted air, polluted water, access to nutritious food, and physical health opportunities. And as the nation's federal government's leading public health agency, the CDC is working with HHS to contribute to this Healthy People 2030. Let's talk about the 5 of these. Economic stability. The goal is to help people earn steady incomes that allow them to meet their health needs. In the United States, 1 in 10 live in poverty, and many people cannot afford things like healthy food, healthcare, and housing. Healthy People 2030 focuses on helping more people achieve economic stability. The next is education access and quality. The goal is to increase educational opportunities and help children and adolescents to do well in school. People with higher level of education, the research shows, are more likely to be healthier and live longer. Healthcare access and quality in the United States. The goal is to increase access to comprehensive, high-quality healthcare services. Many people in the United States don't get the healthcare service that they need, and they need it timely and have high quality. Many people without insurance are less likely to have a primary care provider, and not having a primary care provider, research has shown that they may not get preventative care or treatment for chronic conditions. So that's one of the focuses on the HHS. The 4th one is neighborhood and built environment. The goal is to create neighborhoods and environments that promote health and safety. It focuses on, again, where people are born, live, work, play, worship, and they age. And then the last one, the 5th one, is social and community context. The goal is to increase social and community support with interactions and relationships with friends, coworkers, community members can have a major impact on individuals' health and well-being. HHS does have a guide here that's called Call to Action. And here's all the HHS agencies that are involved in this. Just take a second to look at those. Lots of different organizations, including the CDC, CMS, but lots of other organizations are involved in this call to action. The call to action addresses the social needs related to SDOH and HR and S. You'll see this term intertwined in some of our organizations here in the United States. SDOH, of course, is Social Determinants of Health. HRSN is health-related social needs, and sometimes you'll see those interchanged in some of the documents that are published by our government. But HHS is really calling upon individuals working in healthcare, social services, public and environmental health, government, health information technology to partner and work together across silos to address these 2 very important needs, SDOH and HRSN, in recognition of research findings that social determinants of health account for half of the variation of health outcomes in the United States. And HHS is moving with urgency to advance a series of new policies, as well as funding and training opportunities. Go to another level. In our United States, here's CMS. As CMS, of course, is Centers for Medicare and Medicaid Diseases. The Chief Health Officer did state, as the nation's largest health insurer, the Centers for Medicare and Medicaid Services has a critical role to play in driving the next decade of health equity for people who are underserved. Our unwavering commitment to advancing health equity will help foster a healthcare system that benefits all generations to come. CMS has developed very much alongside the HHS. They have developed a framework for health equity. They started in 22, and theirs goes for 10 years to 2032. And of course, with CMS being the largest provider of health insurance in the United States, they're responsible for ensuring more than 170 million individuals supported by CMS programs, which includes Medicare, Medicaid, Children's Health Insurance Program, CHIP, and the health insurance marketplaces. It's very consistent, as I said, with HHS's Healthy People 2030, and they have their 5 priorities here. Their 5 priorities expand the number 1 is expand the collection, reporting, and analysis of standardized data. That's where a lot of us in the HIM coding world come into play here. Sometimes we think it's only our individual hospital or healthcare system, but there are a lot of databases out there that are collecting data from what we code. Of course, they have other priorities with access to causes of disparities within their own programs, building capacities of healthcare organizations to workforce, advancing language access, health literacy, and increase all forms of accessibility to healthcare services and coverage. But the number 1 is about data. So as we've kind of gone down from world to the nation and different entities in our nation, wanted to go to different things that are affecting healthcare providers and facilities. So we'll start with hospital inpatient quality programs. So if you're involved in the inpatient quality reporting program beginning January of 2024, in order to be still in that program, you must report screening for social drivers of health and demonstrate the hospital's commitment to health equity quality measures. These 5 health-related social needs, again, that HRSN, need to be screened for any patient 18 and above. And as we go through some of these slides, you will see that different agencies or different programs may have a few different mandated SDOHs, and we'll point that out. This one with the inpatient quality program, they are wanting information on food insecurity, housing instability, transportation need, utility difficulties, and interpersonal safety. CMS will require the inpatient quality programs and every facility to report these measures on an annual basis. They actually started this voluntarily in 2023. So there was a voluntary 2023 reporting period. And remember, this is by governmental agencies. So their year actually starts 10/1. So it was actually 10/1. But the reporting period in 23 was January 1st, 23 through December 31st, but that was voluntary. Now it's mandatory. You have to start reporting all of this, and the hospitals will be able to report these measures in the HQR system from April 1st, 25 through May 15th of 25, but you have to be starting to gather that data right now. Let's stay with inpatient for a minute and talk about MSTRGs on the inpatient facility side. So of course, inpatient MSTRGs are affected by what's called MCCs or CCs, major complications and comorbidities, or complication and comorbidities. On 10/1 of 23, these 3 codes were added to the CC listing. So it actually did change the DRG and reimbursement for these 3 items: homelessness unspecified, sheltered unhomelessness, and unsheltered unhomelessness. That went into effect 10/1 of 23. Well, now, just a few days ago, 10/1 of 24, they added more. They added more to the IPPS final rule. And so these are, in addition to the 3 we mentioned, these are also CCs now, which do affect MSTRGs and payment. again, housing is their key right now. They may go every year to add some additional ones. So we will try to keep everyone updated on that. But right now, there are the 3 from last year, which carried over, and these additional ones that do affect DRG assignment. Did you know that these affect Joint Commission? Joint Commission, effective January 1st of 2023, and they tend to refer to these of health-related social needs and not SDOH, but again, you can use them interchangeably many times. But Joint Commission came out and said that these health-related social needs are frequently identified as root causes of disparity in health outcomes. And they tend to use the term HRSN instead of SDOH, but they wanted to emphasize the cause of poor health outcomes for individual patients, and which is a term they felt, the Joint Commission felt, was better suited for describing populations. They looked at their guidelines and their chapters and all of that, but they decided that organizations needed to take up the challenge to implement routine screenings and refer patients to community resources as part of their treatment plan. So there's a new standard that says reducing healthcare disparities for patients is a quality and safety priority. They placed the new standard in the leadership chapter because they felt that it needed, any success of this new venture demanded leadership involvement. So achieving healthcare equity will require commitment, vision, creativity, and sustained efforts at all levels, including the C-suite as well as the board. Here's the actual standard from Joint Commission. Reducing healthcare disparities for the organizations or patients is a quality and safety priority. And there's requirements with that the facility must designate an individual to lead the activity, and they must assess the needs that are determined. And their key areas are these 4: access to transportation, difficulty paying for prescriptions or medical bills, education and literacy. I'm sorry, there's 5, food insecurity and housing insecurity. And they need to be identified for a representative sample of the patients. So it didn't say you had to do it 100%, but there had to be a representative sample of gathering information and then doing something about these 5 areas. Skilled nursing. Skilled nursing does have an area that they will have to start reporting. So the prospective payment system and consolidated billing for skilled nursing facilities, which was an update to the quality reporting program and value-based purchasing program for fiscal year 2025. And it states that the policy has to go into effect for fiscal year 2027 for skilled nursing facility quality reporting program. So if you're involved in that, you want to keep an eye on that and the minimum data set that's required for skilled nursing facilities, because that will come into effect in fiscal year 2027. Okay, let's switch over to the physician side, or the pro-fee side. CMS Framework for Health Equity lists 5 priorities for reducing disparities in health. And again, effective January 1st of 2024, the physician fee schedule final rule actually gave some codes, and we'll go over those, where the pro-fee, the provider, can receive additional work RVUs for some of the work that they are doing. So they really wanted to recognize practitioners who are spending time and resources addressing SDOH that may be affecting their ability to treat the patient. CM also finalized his proposal to pay for separate things, and we'll go over those different items. But the items are community health integration, principal illness navigation, and of course, SDOH. So in the physician fee schedule starting in 2024, so we're in this right now, there are 7 new CPT HCPCS codes that were developed, and we'll go over each of them briefly, but we've given you some wonderful references if you're involved in the pro-fee side of things. I know many hospitals are purchasing and have purchased physician practices and have found out some of the things that are different between coding on the facility outpatient side and coding for the pro-fee side. This again is involving pro-fee. It really is not involving the facility outpatient side. But there's a lot of ifs, ands, or buts. But the CMS felt so strongly that it did need to go down to the level of the physician and the other caregivers surrounding the physicians to help with the SDOH and the risk assessments and getting these patients what they need so that it does help the physician diagnose and treat the patient, but it also helps the patients making sure that they are getting the right medication, the right transportation, etc. And CMS decided it was so important that they were willing to give some RVUs, which usually tends to equate to dollar amounts, some of them not a lot, but to make sure and ensure that things are done appropriately. So there's 7 HCPCS codes there now. Again, we have a lot of detailed information from CMS. I'll go over these slides briefly, but we've provided lots of great references from CMS that if you're in this area, you'll want to really review because it goes over who can do the work. It all has to be at least guided by a physician, and the physician must at least see the patient and start the process, but it can be done by other healthcare types of providers and how to even bill for them, et cetera. So we've given you some good information there in the areas. Again, there's 7 codes here, but we have some that are actually developed for the social determinants of health. We have others that are really focused on community health integration, and others that are PINs or principal illness navigations. And those are really to account for resources when clinicians involve community health workers, care navigators, peer support specialists to furnish medically necessary care or information. The first one we're going to talk about, the first 2 we're going to talk about actually, are in that community health integration or CHI. So the first code is G0019, and it's community, and there's lots of information here. Even if you have a code book or an encoder, it reads so far into where your screen is. I thought, wow, this is a lot of information. But they want to make sure that it's being carried out effectively. This is community health integration services, or CHI, performed by certified or trained auxiliary personnel, including not just the physician under the direction of the physician, but many other types of personnel that can help with this. They've allowed for 60 minutes per calendar month, and that's really important if you're on the CPT side of things, whether it's the facility side or pro-fee side. You know that some of the like E&M codes can be minute-based, can be timed-based. Prolonged services timed-based. So this is another example from the pro-fee side where it is time-based. So it's really important to have the exact documentation and the minutes that are there. So this original one that we're talking about, the first of the CHI, is community health integration. There's the minutes there, it's 60 minutes. And it really is to address and understand the individualized context between the needs of the patient and problems addressed in that initiating first visit. Lots of information here. I'm just going to highlight this because it's pretty detailed, but they have really focused on, CMS is focused on person-centered assessments and what the patient's life story is, where they're living, what their strengths are, what other desires are, looking at what it would take to get the patients to accomplish that physician's treatment plan. And it could be varied reasons. They really wanted to focus on that. They talk a lot about practitioner home and community-based care coordination. This individual may be helping the patient do things like coordinate transitions between healthcare practitioners, looking at community-based services in housing, utilities, transportation, food assistance, maybe even making appointments. I know when my mother was still living, as an elderly patient, sometimes she would get confused about who to call for what, or how do I get an appointment for this or that. And so they're really getting down to different levels of helping the patient to carry out what the physician has wanted them to do. Looking at health education. Again, going back to my mother, when she was still living, I would go to appointments with her and she'd look at the practitioner and say, yeah, yeah. And as soon as that practitioner left the room, she'd look at me and say, what'd they say? So again, if you don't have that advocate with you, you have to build patient self-advocacy skills so the patient can interact with members of teams. And so giving them some education, helping them access. Lots of great items here that CMS is promoting as well as actually reimbursing the physician for or provider for. Going on with the same code, the HCPCS G001, behavioral changes, facilitating things, leveraging the lived experience, providing support, mentorship, etc. And then the next code that follows up to it, and if you know about CPT and HCPCS, there's usually codes, especially time-based codes. There'll be one code after that that says an additional. So this, the first one, the G0019 was 60 minutes. The G0022, you have to have the G0019 first, but this one is if they spend another 30 minutes, and this is per calendar month. Now that sounds like a lot, but some patients may be seen every month by a specialist or every month by their provider for follow-ups, checkups, depending on their chronic conditions. Then we'll switch gears and go over to the 4 new service codes that we describe PIN. We've already described the CHI, but what about the PIN? PIN is Principal Illness Navigation. And there's 4 new codes we're going to be talking about. 2 of them describe PIN, and 2 of them actually describe PIN peer support, which are intended for patients with higher risk items, and we'll look at the higher risk items as well. And there's very much detail about who can do this, perform these, and who cannot, put it that way. So lots of great information we'll go over briefly. So with these, the billing practitioner or the auxiliary personnel has to be under the supervision of a provider, of a physician, and must get advanced patient consent prior to providing this. It can be written or verbal, but it has to be documented. And the billing practitioner actually cannot provide these PIN services more than once per practitioner per month for any single serious high-risk conditions. Now, there's lots of details about that because patient can have more than one high risk, but documentation is very essential for this, and so is the coding of these. Documenting those ICD-10 codes, and we'll go over those as well in a minute, can count as that appropriate documentation. So how do we go about getting this? The billing practitioner initiates the PIN service, usually addressing a serious condition, illness, or disease. And what are some of those? Well, a serious high-risk condition for the PIN PCS is something that is expected to last at least 3 months. That places the patient at significant risk of hospitalization, nursing home, acute exacerbation or decompensation of one of their disease process, or functional decline. And so a condition that really requires a lot of monitoring, revision of what the plan is for that patient. Here's some of the examples of that CMS lists as serious high-risk condition, illnesses, or diseases: cancer, COPD, CHF, dementia, HIV/AIDS, severe mental illness, or substance abuse. Those are some of the items that they actually list in their documentation. So how do we get this? Again, the healthcare practitioner does initiate it. Can be initiated from an E&M visit. annual wellness visit, or some of the behavioral health CPT codes, and those are listed there for you. Again, you must see a patient for the initiating visit before you can go on and do these PEN services, but some of the PEN services include things like health system navigation, person-centered planning, identifying and referring patient or the caregiver or family, if applicable, to supportive resources, and that's important. Lots of home-based and practitioner coordination communication and patient self-advocacy promotion, community-based resources access. So the code G0023 is for the principal investigation navigation services, 60 minutes per calendar month. Lots of great information here. I'll just briefly go over again. There's lots of references for you if you are in this area, but conducting a person-centered assessment to understand all that's going on in the patient's living conditions, work conditions, transportation, utilities, etc. And then coordinating all of that community-based and practitioner-based care, focusing on things like housing, utilities, transportation, food assistance. But it could also be that the patient doesn't get their medication. If they're diabetic, that's going to be very important to that patient's care and well-being. Health education, trying to get them the right information so that they do understand, even helping them secure appointments. Leveraging knowledge of those serious high risk, etc. Just like the other one, the G0023 was 60 minutes and G0024 is an additional 30 minutes, but it has to be very well documented. The PEN PCS, again, a lot of this depends on who actually can do this and document this, and those are all in the guidelines that we've given you references to. But if you look at this is principal illness navigation peer support. So these can be can be some job descriptions that you might have in your organization, such as a patient navigator or a peer support specialist that help the patient. A lot of organizations are now funding those types of to help the practitioners so that and help the patient. To get the right amount of care. They, again, include lots of different services. It really depends on who is doing the service or assigning these. And of course, if the individual doesn't have a way to bill because they're not considered that, then they have other ways to do that. So let's look at the G0140 and G0146. And again, they have to provide services under that, but they can, since there isn't a Medicare benefit for paying navigators or peer support specialists directly, they pay for services incident to. And if you're in the Profi area, you know what incident to means. And great information on that and our references. But if the person meets the incident to requirements and conditions of payment for the PIM services, then auxiliary personnel must meet applicable state standards, including any types of licensure. So the first code, again, is the 60 minutes per calendar month, and it goes through it can be included in that, what needs to be included in the different chronic high-risk conditions, health education, etc. And then the next code, follow-up code, is the one that's an additional 30 minutes. But you have to report the G0140 first. And then if you go an additional minutes after that, the first 60, then you can add this code, the additional 30 minutes per calendar month. So again, it sounds like a lot, but again, if they're working very closely with a chronically ill patient, sometimes that's what it takes to get the person the right care and treatment. The last one, or the seventh one here, is actually just a code and some RVUs connected to for just administering a standard evidence-based social determinants of health risk assessment tool. Now, the CMS publication states not more often than every 6 months. The code actually does not say that, but the CMS publication does. So if you have an individual during the time you're doing an E&M visit, a behavioral health office visit, or an annual wellness visit, and you have a tool, just doing the tool and looking at the tool 5 to 15 minutes, you could assign the G0136 in addition to the E&M level code. What they want in the G0136 is these 4 items: housing insecurity, food insecurity, transportation needs, and utility difficulty. So a little bit different from the other ones that we talked about that they need taken care of, such as different from the inpatient quality or the CCs, et cetera. So you do have to pay attention to which ones that organization wants you to assess. Some of them are very similar. Housing insecurity, food insecurity, transportation needs seem to be very common in all of these, but this one is talking about utility. If the patient doesn't have the right utilities, then that could make, especially in chronic conditions, make them sicker. Let's take a look at some example assessment screening tools. We've given you links to all of this in our references. These can actually be electronic. They can be paper. You give the patient a piece of paper and they fill it out, kind of like when you go to your physician's office and they say, you know, fill this form out before we see you, or the dentist or wherever. It could be one of those, and they could be scanned in. It doesn't have to be completed by a healthcare practitioner. It could be completed by the patient, but then the documentation does have to say it's reviewed and documented and discussed by the clinician and how long that took. So various ways to do this. Many of the facilities that we work with are looking at putting this in the EHR, a certain place, maybe case management does more of it, care management does, maybe quality assesses this. Various departments or individuals can actually perform this in your facility or in the outpatient arena for the facilities or the prophy area in the physician office. Here's just some examples where it's yes or no. Some of them have numbers so that the numbers correspond to maybe even the CAC, where your CAC is assigning these codes, and the coder can look at those and to accept or delete, exchange. So various ways to get these assessments. So some of them have yes, no. Other assessments that we have seen have more details about often, sometimes, never. Again, were you worried that your food would run out? Worried is a food insecurity. If you actually did run out, then you know that is a different code in a different area. So how long did this happen? How long did you have electricity, gas, oil, water? Or did a company threaten to cut you off because you don't have enough money to pay it? Did you put off or neglect going to the doctor because of transportation needs? You couldn't get to the bus because of some limitations in your gate, et cetera. Or someone, a family friend, couldn't take you then. So all of this, again, depends on your individual facility and where you want to invest in this. Again, it is really just taking some time. It takes probably more time to get it in an EHR than anything. So I know a lot of facilitators are doing paper and scanning them in, but if you can get it automatically in, I think that may be worth it, especially as this keeps expanding. And we'll talk about other things that they have expanded. This one was different. This is, you have problems with any of the following. Do you have lead paint or pipes? Do you have mold? Do you have water leaks? Do you have smoke detectors that are missing or not working? So again, you can get as detailed as your organization would like. Food, again, how much have you run out? Did you just didn't buy some types of food because you were running out of money? You selectively went to the grocery store to get what you need. Did you miss some medical appointments, etc.? So once those screening assessment tool is completed, you want to make sure that you do get that in the EHR. It can be scanned in, digitally entered, because if you're going to capture this data and all the codes we've been talking about, all the databases, all the way up to the World Health Organization, we're going to have to capture these codes. Now, I do want to say that each facility does need to make a decision which categories to prioritize, because if you look at the range of social determinants of health codes, you can be coding so much detail. Sometimes I think you have to prioritize, because those of us in the coding world are saying, okay, there's got to be a balance here of how much the coder has to look for. Yes, we certainly want to do on the inpatient side the correct codes, the correct DRGs, outpatient side as much accurate as possible. With all of the codes on the pro fee side, the same thing. You want to make sure that you're capturing the information that's needed for the facility, for the provider to get the adequate reimbursement. That's very important. And what other measures do you need to do to go outside of that and look for these social determinants of health? I really do think it needs to be a priority from the top for the leadership to do that, as well as a policy and process documented for your CAC vendors and for your coders, because it may pick up lots of things, or it may be in a part. We're working with a couple of different hospitals that where it is in the EHR, their CAC can't get to or can't read. So the coders, it is a manual looking at that section of the EHR. So that's important as well. So what is the policy process of what you're going to collect and how you're going to collect it? We've talked a lot about various settings, and we've talked about in the United States, we talked about the hospital inpatient quality measures, the inpatient DRGs, MSDRGs, the pro fee side, physician-based, joint commission. We've talked about skilled nursing facilities. Upcoming, I have read that it may affect dialysis centers, may affect inpatient psychiatric hospitals, as well as all post-acute care providers. So it's continually expanding. If you don't think it's hitting you yet, it probably will. Here's the broad listing of the ICD-10 diagnosis codes that are located primarily in the Z55 to Z65. I just put this up here in case your participant that's not a coder. This is where they're located. And then I've given you some screenshots about what some of these codes even look like. You say it's in the Z59 category. Well, what does that even look like? And there's some descriptors here just giving you. So these could be potential screening outcome code assignments, lack of inadequate food insecurity, for instance. Again, some others that could come out of that screening with if the person was housed, that they did have but there was a foreclosure, et cetera, or if they are homeless, if they're sheltered homeless, or if they're living on the street, et cetera. So very much detailed. So your questionnaires, your assessment need to be this specific as well. Here's some other inadequacy of housing utilities, electric, gas, oil, and water, because some are wanting that information, others are not. Do you have enough? Lack of air conditioning. We live here in Florida. There's some places that don't have air conditioning because it's costly. That can affect someone's health, especially if they have a lot of allergies or, asthma, things like that. And of course, transportation insecurity. Here's support groups, other family circumstances. This could also be collected if your organization decides that's something important that you really would like to see reported. If you're in the coding, let's look at the official coding guidelines quickly about social determinants of health. As you all know, it's not necessarily needed by the physician or provider. Most ICD-10 codes need to be assigned per the official coding guidelines by the physician or provider documentation. So the physician must stay it. But here's one of the exceptions. One of the exceptions, kind of like BMI, is the social determinants of health. It can be documented in the medical record or the EHR in the official medical record from clinicians involved in the care of the patient who are not the patient's provider, since this information represents social information rather than medical diagnoses. So, for example, coding professionals may utilize documentation of social information from social workers, community health workers, case managers, nursing, if their documentation is included in the medical record for these Z codes. Patient self-reported documentation also can be used to sign codes for social determinants of health as long as the patient self-reported information is signed off, incorporated into the medical record by either a clinician or a provider. Giving you lots of information here. I hope it has been helpful. In conclusion, it really is important for integrating these SDOH because of all the way up World Health down to our nation with CDC, HHS, CMS, as well as healthcare practices, hospitals, quality measures. And it's really important for healthcare providers, facilities, and coders to stay updated and informed regarding these code assignments, requirements, and benefits. And I cannot highlight enough the accurate data that impacts all these agencies, all of this, all the way up to the World Health Organization. We've given you four slides of references. If you're interested in any of these, again, going back to the World Health Organization or the CDC, but anything, especially if you're in the pro-fee side, there's some wonderful information about that in these, as well as if you're involved in the quality measure reporting, tells you exactly how you need, what dates you need to report it, etc. So here's all of those for you to read. And I think now I will turn it back over